Hi, good afternoon. It's Charlie Krasner. I'm here with my sidekicks, Jessica. We're going to talk today about, I'm glad you all joined us. We're going to talk today about an infection control issue, which is sort of, if you work in the hospital, sort of like takes everything and just everything is involved in this. We want to reconsider MRSA isolation precautions. Do we really need what we're doing, or is it overkill? And does everybody have the slides up? And I hope we want to hear from people about what they're doing in their facilities and what their thoughts on it. So, since this is the Antibiotic Stewardship program, I always talk about C.Diff. Before I get going, I came across this abstract that's going to be published very shortly in the Clinical Infectious Disease. And, we've talked about PPIs. Do they increase the odds of infection? Does acid suppression increase the risk that C.Diff develops? And there's been some questions back and forth. Some people say yes, some no. And this was sort of a definitive retrospective study. It was from the Hospital Corporation of America. They looked at all their hospitals, and they looked at more than 1 million patient records, and they did a cohort study retrospectively to see what factors seemed to increase the risk of getting C.Diff over somebody who didn't have infection. And so they definitely felt so when you're dealing with more than 1 million patients, you can get a very good results. And they said there was definitively an increased PPI risk of 44%. So that means if you had 100 patients on Rocephin, and let's say 20 got C.Diff, you had 100 patients on Rocephin and they're on Protonics, you don't get about 28 of them would get C.Diff. So it definitely, the odds were very strongly positive that the use of PPIs increased the risk of C.Diff. H2 antagonists, Zantac and stuff, was not as significant, probably because they're not as potent, but did increase risk by 13%. And as you know, a lot of patients are put on PPIs in the ICU and get transferred to the floor. They get continued on it, or they come in it, they don't know why they're on it. They had gastritis 5 years ago and they're still on it. So it's really, if you work with your infection control antibiotic stewardship, their comment was that reducing acid suppression therapy combined with antibiotic stewardship may greatly reduce the incidence of hospital onset CDI. So again, it's an easy thing to do. Why is this patient on a PPI? The other risk factors, just to talk about antibiotics, the antibiotics they felt the worst were the carbapenems, things like meropenem, Zosyn, and the 4th generation cephalosporins increased the risk about 100%. So, these are significant risk factors. What was interesting is, tetracycline was known to reduce C.Diff, but the clindamycin actually, they weren't sure why, maybe because it wasn't being used very much. They found a decreased risk with clindamycin, which sort of goes against our second nature, I think it does. But the big take home is that the 4th generation cephalosporins, Zosyn, carbapenems double your risk compared to some other antibiotics, and the PPIs. Okay, so if you're into antibiotic stewardship, you may also want to look at PPIs and maybe tell your hospitalist, does this patient really need to be on it, and maybe get them off, particularly if they're going to be on antibiotics. Okay, so that seems like 1 million charts. It seems like it definitively answers that question. All right, so I'm going to give you the next few slides. I'm going to talk about infectious disease precautions in hospitals, a little bit of history of it, and how we ended up on contact precautions 12 years ago. So 1910, barrier nursing, where nurses would use gowns, was introduced. And not much changed until about the early 1970s, when they came up with specific precaution categories, like respiratory precaution, wound precaution, drainage precaution. So you'd have specific approaches to each one. But then HIV came along by the 1980s, and instead of trying to guess who's at high risk, who's at low risk, who has infection, we came up with universal precautions. Assume that every blood and body fluid is infected, and so we don't treat patients differently. We assume you got blood, you got pus, that you're at risk for infection. And so every patient is thought to possibly have an infection. And this was combined with standard precautions. Standard precautions, yes, you do universal precautions, but yes, if somebody has an infection, they have diarrhea, you want to combine it with gloves, gowns, and masks to protect your exposure to body fluid. So we had standard precautions and universal precautions put together. But then in 2007, for the first time, the CDC recommended what they call contact precautions. And they were recommending gloves and gowns for all patients who were infected with multi-drug resistant bacteria. And so that makes sense. You have somebody who has an infection, he's got pneumonia, he's got a MRSA wound infection, he's got, whatever. You definitely want to use, precautions. But for the first time now, it was extended to patients who were asymptomatic, patients who had no obvious infection, but had been identified as being colonized. So not only just infected, but those colonized, that we should do contact precautions. And the usual target being VRE and MRSA. And so this was a big extension from actually infected people to those who are only colonized. And they felt we should do this contact precautions. So this is not a new concept, contact precautions. This was Dr. Schweiner in 1656. He introduced the first contact precaution outfit. And it was this was in Rome, 1656, and they had about 500,000 people had died of plague. And so they felt that the plague was transmitted by bad air. It's called miasma, so it's bad air. So he developed this beak, and he put like flowers and spices inside the beak so that it would neutralize the bad air. And then he had this wax gown. So it's very similar to what we see nowadays with people walking around with personal protective things. But it is not. It has been around about 100 years, and you can actually buy this for Halloween stores. They'll sell you it's called the Black Death mask. All right.
I'm gonna look that up. Where is it?
Anyways, so contact precautions. This is an opportunity cost. Okay, it's not something benign. Putting somebody, wearing gowns and gloves and masks. It's not saying, oh, simply do it. There are a lot of drawbacks, and anybody who works in the hospital can point them out. And it comes at a cost to other things that we could be doing. So, first of all, it's extremely burdensome. When you walk down a hospital and everybody has to be on, gowns and gloves, it gets very difficult. And if you're busy, it really gets frustrating. And so they found out the more patients are in contact precautions, adherence by healthcare workers fall off, the greater the use of isolation. If you only have a few patients, people adhere to it. When you get to 60, 70% of people in isolation, it gets, people get tired. In the emergency room, the patient oftentimes can't get moved out of the ER until they get a special room. So there's definitely delays in the emergency room. And then, as you know, when you try to get somebody to a skilled facility, they throw up barriers. So it takes an average of almost 2 days to get somebody who's in contact precautions discharged to a skilled facility. And, I know the hospitals here are wall-to-wall people, particularly with the flu going on. So there is cost to this. As a healthcare worker, as a physician, nurse, you get tired of putting this on. And so these, oftentimes you do like a drive-by, you just wave at the patient instead of going in to examine them and not putting on the thing. And so obviously the patient feels he doesn't know what's going on. He's unhappy. He says, why am I in this? His satisfaction goes way down. And so, and finally, the cost is significant. And then environmental burden. We are throwing away so many hundreds of thousands of gallons into the waste. I just can't imagine. It must be millions and billions of pounds of this junk. So contact precautions are not, oh, let's just do it. There are costs to it. And so when you look at states, when the outbreak of MRSA, community-acquired MRSA came around in the 2000s, a lot of legislatures and hospital systems said, oh, we have to start screening, do contact precautions and screening. And so it changes for a lot of things, but presently California, Illinois, New Jersey, and Pennsylvania, as well as I work in the VA, the entire Department of Veterans Affairs require active MRSA hospital surveillance. Everybody in those states, the VA has to be screened for MRSA on admission to the hospital, not just the ICU, and then put in contact precautions if it's positive. In California, which they go overboard on everything. If you fail to follow mandatory culturing and reporting, this can result in sanctions, fines, and even jail time for members of the hospital. Nevada is not like that. I found that since 2011, you have to submit data to the National Healthcare Safety Network related to healthcare-associated MRSA infection rates of patients by the patient care location within the hospital, as well as MRSA bloodstream infection. So they are just, in Nevada, this place, it's just reporting of cases. All right, so what is some of your, before we talk about the cost of doing MRSA screening, what are some of the facilities that you guys do? Can you tell us what your policy is in terms of screening for MRSA and reporting it?
Hi, this is Kara at Carson Valley Medical Center, and we only screen ventilated patients, but not any other type of patient unless there's a direct reason, like we're checking a culture or whatnot.
All right, so checking your culture, obviously that's looking for an infection, not looking for screening for just colonization. So that makes sense. Any other places?
This is Carrie Jo at the VA. We screen admissions, transfers, discharges, and deaths in the community living center. And we used to do it in acute care and ICU, but now in acute care we just do admissions, and ICU we do admissions and transfers in.
So the CLC is like a nursing facility. What do you do when the patients are positive? I mean, do you keep them in isolation, or what do you do when
they go into enhanced barrier precautions? The CLC, we concentrate more on education, because you can't keep them in their room. So it's more of a, keep your hands clean, visit in the areas, the common areas. And then housekeeping concentrates more on all the high touch areas, disinfecting and cleaning that, because they get problems with outbreaks and excuse me, and since they're moving around and many have dementia, it's a constant battle. CLCs are hardest place.
We have Amy McCombs from Renown. Tell us what you do there.
So about 3 years ago, we stopped doing any screening for VRE and MRSA, and we have not seen any increase. So we only isolate using contact precautions on any active infections, and we isolate throughout their stay, unless of course they're at our skilled or rehab facility, then it's a little different.
So do you know what percentage of people are in isolation now versus when you were doing the contact?
Oh gosh, a lot less. Probably 40, 50 less patients a day.
Are not in contact.
Mm-hmm.
That's wonderful. Right. So let's go over some of the data why we may want to think if we consider doing contact isolating. So the question is, does detecting and isolating MRSA, so looking for asymptomatic colonization, does it lead to improved infection rates? Okay, does it, are we nipping infections in the bud by isolating and putting people in contact isolation, even though they have no signs or symptoms of infection? So one of the studies was in the New England Journal, and this was a multi-hospital investigation, and they had a very active surveillance of everybody to look for MRSA and VRE. It basically led to a doubling of the amount of patients in isolation, but when they look at transmission rate, there was no change in transmission rate. So oftentimes you say, oh, this patient's got MRSA, but what they can do is they can do a genetic analysis of that MRSA and see was it related to other people in the hospital, or was it not? Was it just a community-acquired one? So oftentimes, even though it's MRSA, when you look at these infections, it's very rare that the person who develops MRI has actually had it transmitted from another patient. It's almost always that the patient's coming in with it. So they found it doubles contact isolation, but no effect on transmission rate. What they found is that most infections of MRSA are from the patient themselves, and rarely from patient to patient. And they looked at ICUs in another study, where people acquiring MRSA infections in the ICU, where they actually from other patients, and it was less than 2% of ICU patients who got the MRSA infections actually were from transmitted from somebody else. So you have maybe 5% of your IC patients getting MRSA infections, and only 1 out of every 50 of those 5% got it from another patient. So it's very rare, maybe 1 in 500 to 1 in 1,000 patients consistently who develop MRSA, who get infections, are transmitted. So you have to basically isolate about 1,000 patients to reduce maybe one case of person-to-person transmission. The CDC did a study, we published in the New England Journal, and they found that 4% of hospitalized patients got healthcare-associated infections, so all types of infections. Approximately only 1 in 20 of these healthcare infections were MRSA, so less than 1 out of every 500 patients actually got MRSA infections in the hospital, and most of these were from the patient's own nose or axil, where it was endogenous, so not patient to patient. And so they felt there was no evidence that contact precautions added anything over improved use of standard precautions. So there's really no evidence that it helps. So there was a nice editorial in JAMA a few months ago by Dr. Wilson, I believe his name. He's the world's expert in isolation. He calls this MRSA Exceptionalism. MRSA is obviously a threat to patients, but so are a lot of other infections. You know, should we specifically focusing our energy on MRSA at the risk of cutting back in other areas? You know, he said MRSA accounted for only 11% of hospital-acquired bacterial infections, of which 89% of other hospital-associated infections were other bacteria. And he says universal MRSA screening may detect more MRSA colonization, but will miss other serious infections. So we may be putting people in contact isolation, but we're missing, you know, the fact that you know, they have ESBLs, CREs, and everything. So it's really like we're pouring all this effort and money into MRSA isolation at the cost of all those things we talked about. Probably no benefit at all in terms of reducing MRSA, and not really addressing the fact that there are a lot of healthcare-associated infections, and MRSA is only one small subset of it. So, whether contact precautions have anything to optimal use of modern standard precautions is not known. Earlier studies suggested some benefit to contact precautions, but all were done before the widespread use of things like chlorhexidine, bathing, efforts to improve hand hygiene and environmental cleaning, which incidentally work not to just prevent MRSA, but all infections, okay? And so, you know, having basically universal precautions plus standard precautions plus these other interventions don't just deal with MRSA, but they probably reduce the risk of all infections that are important. And so this was what he talked about was that there are presently 40 hospitals, including Dartmouth Medical Center, have totally dropped strict universal MRSA and VRI contact isolation procedures for up to the last 10 years. And what they've taken is a much more, instead of, guerrilla approach, they have a much more nuanced and selective approach. So obviously, they will put somebody who's got active infection. You got draining wounds, you got diarrhea, you're going to want to put that person in isolation, okay? So those are people, obviously, you want to continue contact precautions. And those are not people who picked up on screen, but those are people with active infection. They say bathing patients. When you're bathing patient and there's a lot of exposure to the patient, so they probably should be wearing gowns and gloves when they're cleaning patients. And focusing on evidence-based prevention strategies to decrease risk from all pathogens, such as sterile central line placement. The nurses tell you about sometimes doctors will put lines in without even gowns or gloves. Using chlorhexidine body wash, a big focus on hand hygiene by really focusing on all healthcare associated infections and active infection. They feel that you can eliminate contact precautions if patients simply colonize with MRSA and VRE. And so this is some of the things that we're trying, or other places are trying. Nosing, I know the VA is using nosing. What are you guys doing with nosing at the VA? Carrie?
Hi, this is Beth. We did the nosing trial in our CLC, but we're not using it at this point on like surgical or anything else. So we're not really using it.
What would be the indication would be for trying to
the indication, like for surgical patients, the short-term patients, you use the nose in, if the CHG bathing, you wouldn't have to do any isolation. You don't screen for MRSA or anything like that. You're just more proactive versus reacting to a screening culture. Like you said, it takes care of more than just MRSA.
Yes. And the other thing is, I know at Northern Nevada Medical Center, we're using the UV lights, and that has been shown to be very effective. Are you guys using it anywhere else?
We have the Xenix at Renown.
All wards or just particularly?
We only use it in the ICUs on all discharges, all isolation discharges, and in all of our procedural areas every night. We don't have enough for every.
And it seems like it's been effective,
Yeah, it does.
all infections. Some people recommending the Pearson ointment. They had some studies where they were trying to decolonize all these patients who had MRSA, and eventually what happened to be the MRSA would develop resistance to Pearson. So it's probably not something you'd want to use. Somebody if you have contact, the patient's just colonized, but maybe somebody that's an active case, you may want to use that. And then on the bottom, I know the VA is trying to get some electronic monitors for hand washing. Is that right?
That is right. We can't wait. Unfortunately, we can't tag it to a patient, to a specific employee, but we can tag it to the unit, and hopefully maybe to their service, physician versus nurse versus something else. But we're working on that.
We also use UV lights on all the units. CLC, in the OR, and in the bathrooms on the 2-bed wards when, because if you'd only discharge one patient and there's another one in there, they can UV light the bathroom.
And how long do you use the UV light for? 5 minutes, 10 minutes?
It runs for 4 minutes, a run. So you have to do one side of the bed, the other side of the bed, and then the bathroom. So that would be about 12 to 15 minutes.
That's pretty quick. Nice. And so I think contact precautions seemed like it was a reaction, overreaction to an epidemic that was developing. And I think with more modern things that we're doing these days, with a focus on hand washing, coaxium body wash, a much more focused approach to isolating only patients who have active infection using universal standard precautions, I think it would be reasonable to stop putting people in isolation just because they're carrier. Have your guys' thoughts on that?
It seems to be working for us, right?
Yeah,
The rates of it remain stable.
Mm-hmm.
Do you remember when Sweden was the gold standard years and years ago, where they actually tested the nurses, employees, and if they were positive, they were sent home, and they had to be negative to come back in, and their rates were really low. But that was a long time ago.
I know some infectious disease doctors for now were disagreeing with it, and what was their argument against taking them out of human?
Wow, that was over 3 years ago. So just
There
that
were
the
huge
CDC
differences.
guidelines still supported putting that, like you showed up there with the active surveillance and then isolating everyone, even if they were just colonized. So the CDC still supported it. And then there were several other older articles that were cited.
Well, yeah, a physician wrote, when Dr. Dinza recommended not doing it, a physician wrote, it was about a 12-page article with about 20 some odd references, but all the references were, of course, older references that supported it. So.
Right.
And as a compromise, we report those rates anyway, but it's something that we've watched very closely over the years. And again, as Amy said, our rates have actually declined, probably due to the comprehensive approach to
Probably the
infection
hand hygiene
Yeah.
and chlorhexidine and the cleaning. Yeah.
About the new Pearson, I believe that new Pearson, unlike, is only specific to Staph aureus and strep. It doesn't hit neurococcus, it doesn't hit gram-negative rod, so it's more selective versus.
That knows and does, I don't know anything about that.
I think it's.
Beth, what does that hit?
Broader.
It hits some bacteria like staph and I believe like VRE. It also covers viral pathogens.
What's the active ingredient of Nosen?
Alcohol.
It's alcohol.
Yeah.
Probably burns, you would think, huh?
Yeah, I think so.
It doesn't. It's got a citrusy flavor. Smell.
Berries are sterile.
So I think the bottom line is that, if, contact precautions, their day has come and gone, that it's really, we've superseded with good infection control measures, hand washing particularly, gowns and gloves for drainage, that we can do away with it and, have a lot of benefits, save money, save the environment, make patients happier, quicker patients in and out of hospitals. Do any of you else have any experiences stopping or what are you doing with MRSA isolation patients?
Well, at the VA, we're still required to isolate everyone, but the MDRO program office, central office is looking at the recent studies about taking patients out of contact isolation. We've also had conference calls about it, and Dr. Evans, the infectious disease, the head of the MDRO program, said there wasn't quite enough evidence yet, but that was some months ago. And they also published a study in 2011 that showed a reduction in HAIs, but we use a bundle approach. So, it's surveillance, isolation, hand hygiene, changing the culture, but that was 2011. So they are looking at what you're talking about, Dr. Krasner, of maybe looking to see if we can stop some of the isolation. But as of 6 months ago, I think that was about when it was, he said there's still not enough evidence for them to decide to change the whole bundle approach.
What are you guys doing with C.Diff carriers? Maybe are you guys, if they're continent stool, you're not putting them in isolation?
No isolation if they're continent stool.
Yes. That's another, we've always assumed that they're very contagious, but if somebody's continent stool, there's very little evidence that good hand washing that you transmit it. So patients who are no longer having diarrhea can be taken out of isolation. So
That's what we do too.
this is good. Yeah, so hopefully, I think it'll be a more pleasant place to work in the hospital. And by focusing on what's important, the hand washing and the sterile techniques when you put lines in, Corhexidine body wash, wearing gowns when you bathe patients, I think the patients benefit, the bottom line benefits, and it's a better place.
So Dr. Krasner, this is Kara at Carson Valley Medical Center. So we have a unique challenge. So our critical access hospital conditions of participations came out, a new version, October 2016. And they specifically state that you have that, as far as isolation and MPRs go, that we have to follow nationally recognized guidelines such as APIC and CDC and OSHA and those kind of things. So when I did the research back then, all of those guidelines were still saying, and I reached out to our state, they were still saying to isolate for a history of MDRO. So I think it's, as far as work and our conditions of participation, we have to abide by that.
It was a big debate at APIC 2 or 3 years ago. There were several sessions about contact precautions versus not contact precautions. And there's definitely two groups, two sides.
Right.
Yeah.
The right and the wrong.
Yes. That's like saying, there's a, whatever, there's two sides to global warming, right? don't know yet.
Yeah, we don't know yet.
Does anyone else have any comments or questions? Please feel free to unmute yourself with the icon in the lower left corner of the Zoom window, or with *6 if you're joined by phone.
And then, Kara, does it actually list MRSA as an MDRO? Because it's not a multiple drug resistant.
Yeah, I haven't read it lately, but from what I recall, yeah, it says, I think it specifically says like VRE, MRSA, and it says other multi-drug resistant, something like that. I haven't read it in a while, but.
Well, maybe it's time to question that, yeah. So you guys may want to have a chance to just review what your hospital policy is and talk to your physicians, and you may want to consider changing it, but it doesn't mean go crazy. It means that you do the good standard precautions and the hand washing, all the stuff you're doing as a substitute for putting people in isolation. All right, thank you all very much.
Thanks.
Everyone.
Thank you.